So hello everyone, and welcome to this this interview with the speakers from the session on the gastro-entero pancreatic factors that we had at the EASD this morning. All the speakers are here to have a chat to you, and we're going to talk around the general topic of targeting the gut or the pancreas to treat metabolic disease, diabetes and obesity. So I'll just start by asking the four speakers to introduce themselves, and we'll start with Christoffer.
Yes, thank you, Fiona. My name is Christoffer Martinussen, and I'm a medical doctor and PhD. I'm currently working at Hvidovre Hospital, and my profile is primarily clinical research, focusing on gut hormones and bariatric surgery.
Okay, Frank?
Yeah, my name is Frank Reimann. I'm a biochemist in background, and as you know, I'm working with you quite a lot. And the focus of our lab is on gut hormone secretion and also on gut hormone target cells. And we use different techniques to investigate what happens at the cellular level, mostly.
Elina?
I'm Elina Akalestou. I am based in London. I am a postdoc with Guy Ratter in Imperial College, and the last 10 years I've been trying to unravel the mechanism around bariatric surgery with regards to type 2 diabetes and liver disease.
Good. And Minyoung?
Hello, this is Minyoung Lee from Yonsei University, South Korea. I'm working as a medical doctor endocrinologist, and this is the first presentation in the EASD virtual meeting, and the theme in the pancreatic cancer-induced diabetes is the very first theme after I started to major in endocrinology. So I am really interested in and eager to find the answer about the molecular pathways in it. Thank you.
Very good. Welcome, everyone. So I'm going to kick this off by asking Christoffer. So the general theme of this session was about targeting the gut and targeting the pancreas. And perhaps the easiest way to target the gut is to do it by asking people to change their diet. So Christoffer perhaps starts off by telling us what you think are the possibilities of using altered diet to treat diabetes and metabolic disease.
Yeah, thank you for that question. I think it's a very interesting topic. First of all, I think gut hormones have a great potential for the treatment of this metabolic disease, and we know that they are already used for treatment of obesity and type 2 diabetes with the GLP-1 agonists. Used for subcutaneous administration, but yeah, the idea is that perhaps it's better to stimulate these hormones naturally by modulating what we eat in a way to enhance the endogenous gut hormone secretion. And I think there's a potential because now we have a good idea about the receptors and the pathways involved in gut hormone secretion, and also the molecules that can stimulate the secretion. So the next step is to figure out how to manufacture the food components, like functional foods that can activate these secretory cells, endocrine cells. There has been some research into encapsulated foods, but and probably we need to look at many different pathways agonizing different receptors to fully stimulate these endocrine cells. As Elina talked about, there may be bile acids could also play an important role in the bile acid receptors. Also, we know that the SGLT1 receptor is probably very important. The free fatty acid receptors and also the calcium sensing receptor for protein. So probably we need to interact with a lot of different pathways, but still there's a lot that we still don't know, and also the challenge that some of the receptors seem to be located at the basolateral membrane of the enteroendocrine cells. So how do you activate this this receptor when it's located when it's not located on the luminal side of the epithelium? So there's a lot of things that we need to explore.
But your dietary intervention, the data you showed this morning, showed that you can really only get higher gut hormone levels if you feed people more, which then actually is counter sort of productive, really, to feed people more to get the higher gut hormone levels when you want to reduce food intake. So how are we going to get around that?
Yeah. Although if I Christoffer showed mixtures of lactose, was it, and proteins. I think Japanese have done protein preloads only, right? So and I think they had beneficial effect on glucose homeostasis afterwards. So one could do something like that. So you would stimulate the gut hormone given with a caloric load, but you would then improve the glucose homeostasis if your preload would be glucose free.
Yeah.
Would you agree with that? That would be an option, wouldn't it?
Yes, I think we also would be an interesting design to look more isolated at the macronutrients with isolating protein and carbohydrates. You would probably get more clear results. But with respect to the Fiona's question, I completely agree. If it's only caloric dependent, then it's not that interesting. But we have also seen from animal studies that some of these that some carbohydrates that are in fact not metabolized are still able to stimulate the L cells, and I think that's very interesting. That perhaps we can stimulate these cells without providing energy to the organism. That would obviously be the very very interesting, but still we need to more to look more into the secretory pathways. How exactly do we activate these cells without calories?
So Frank, what's your thought? Do you think it's got more chance of targeting the GLP-1 secreting cells by diet, or would you have to target these receptors that Christoffer was talking about using pharmacological methods?
Difficult question. I think diet would be ideal, but if there is the caveat that you then would have to increase caloric loads, that would obviously be counterintuitive. I think taking this back one step, it's quite evident that you have spare capacity of gut hormones. So if you use some of these Reimann gastric bypass patients where you look at the GLP-1s and you deliver the food either via the normal route, like orally, where it then bypasses the stomach, or there were a few cases like that, or you give the food via the stomach, then there was a different GLP-1 profile. So in the same patient, you have a spare capacity of GLP-1, which is the first thing that you need to show, that there actually is something that you could recruit beyond what is normally recruited in normal feeding life. So I think there is a spare capacity. And then from our research, we would think that, as Christoffer also pointed out, you probably can't just engage one receptor. You probably need a mixture of receptors. And our work points toward that you need something that increases CAMP and something else that increases calcium. So when they come together, there seems to be a coincident sort of detection. And I would think it's probably to avoid this caloric load problem, better to find small molecule agonists, for instance, that go for these receptors. The problem then is that these receptors, of course, are not only on the enteroendocrine cells and are not actually facing into the lumen. So you can't just trap them in the lumen, the agonists. They need to actually see the basolateral side, which then might have problems with hitting other cells in the body that have not beneficial effects when these receptors are activated. So I think there's still a lot of research to be done before we have something.
And Christoffer, I guess, you know, with diet, you're more thinking of targeting enteroendocrine cells in the small intestine, whereas if you go for therapeutic agents, depending on how they're administered, you could target the distal gut more. Do we think that one of those might be more beneficial? Perhaps the fact that the diet doesn't do so much unless you eat a large amount suggests you are having to target cells further down the gut.
Yeah, I think our knowledge from gastric bypass surgery tells us that we need to target the distal gut to generate these drastic hormonal changes, and most research has focused on GLP-1, but we also need to look into to other hormones in like PYY, neurotensin, oxyntomodulin, and probably it's a cascade of hormonal changes that will that needs to be mimicked. So we that's what makes this difficult, is because the real problem is that still there's a lot that we don't know about control of satiety. How is it actually regulated, and it's such a complex, delicate system. So you one thing is to look at how to stimulate these gut hormones. Another is to look at how do they actually interact. There's evidence that there may be synergistic effects between them. So, but I think the distal gut has a great potential in terms of treating metabolic disease. That's my idea.
Frank, what are your thoughts about targeting distal gut?
Yeah, same. I would, if I would preferentially target something, I would target the distal gut based on bariatric surgery. Although I don't believe that the hormone changes after bariatric surgery explain the entire outcome, and we can discuss with Elina maybe to bring her into the discussion. But certainly, it seems that the hormones that come from the more distal small intestine seem to be the one that are strongly elevated after bariatric surgery and always correlate with beneficial outcomes. And GLP-1 is one of those, but I agree there are others that hasn't been looked. Even secretin has been linked to bariatric surgery now, and we need to look at these other hormones too.
So I think that's a good point to bring in, Elina, because you've been studying effects of bariatric surgery on outcomes in eyelids. So what are your thoughts about what it is about bariatric surgery that actually affects the eyelids in such substantial ways to improve beta cell function?
I completely agree. And although that's why I use the jigsaw slide when I present this kind of data, because I never think that it's a big puzzle and each one of us focuses on one thing. And I always remove the weight loss, but that's not correct. The weight loss is also a part of this. It's not, I'm not as hardcore as like the direct trial that focuses on the weight loss. I think that this is definitely part of it. I think GLP-1 is a really big part of it. I do agree that it's more gut hormones and maybe not even just gut hormones. The study that I started 3 years ago shows that SGLT2 in the kidney is almost eliminated by expression after bariatric surgery. So maybe we are not just absorbing less by reducing SGLT1 in the gut, but maybe it could be the kidney that stops the reabsorption of glucose. Recently, I started a study on the adrenals and their relationship with the gut, because I see that the glucocorticoid action is significantly reduced after bariatric surgery. So I don't even think that it's just gut and pancreas. I think that bariatric surgery is means to an end for us to unravel the mechanism of a lot of organs communicating with each other. And I personally, I started working into kidney and adrenals on top of liver and gut and pancreas, because I think there is a community. Of course, it's the point of what's the first line and what's the other organs just following through, and they are changing what they're doing according to what the gut is doing, or is it the other way around? But I think that it's clear that we need a cocktail of drugs if we want to replicate bariatric surgery, and that cocktail is not just GLP-1 receptor agonists, because we have that and it's not working as well. It could be SGLT2 inhibitors into that cocktail. It could be metformin into that cocktail, an agonist of PYY that is higher in pharmacodynamics and kinetics. But yeah, if we do want to replicate this effect, we definitely need a lot more than just liraglutide.
Perhaps I can bring in Minyoung as well here, because you've been looking at Wnt signaling in pancreas and the effect on pancreatic beta cells. So how do you think this could fit into the picture of how to either how islets are damaged in diabetes or how you could actually improve their function?
Thanks to the lots of fruitful discussions, there was very lots of novel things about the beneficial things about the bariatric surgeries. And I think the most strongest point in our prospective cohort study was that we were able to exclude the effect of these total beneficial effects of bariatric surgery because we had a very appropriate controlled subject who had a very same PPPD as pancreatic cancer patient did. Because all those prospect cohort study patients had received PPPD as same. The beneficial effect of PPPD might have affected on the improvement in insulin secretion and hemoglobin A1C and fasting glucose level improvement in several ways and several metabolic pathways. However, because there was a same metabolic and surgical condition on both pancreatic cancer group and non-pancreatic cancer group, the significantly improved hemoglobin A1C and fasting glucose levels in pancreatic cancer patient, as well as less decreased insulin secretion in pancreatic cancer group has to be noticed and has a meaning to the researchers to notice and make a further research on it. I think that's the point.
Can I ask you, you identified, I think it was Wnt5a as possibly the mediating factor. Did you do anything towards inhibiting the Wnt signaling pathway? I know you can't do that in your human patients, but you could possibly do some in vitro experiments where you would apply Wnt5a and or a Wnt antagonistic thing like DICOP or something to see what happens to pancreatic islet function.
Oh, thank you for making those points. Actually, we performed a ex vivo experiment as well. And we isolated the mice islet and treated with Wnt protein. And we found that glucose-stimulated insulin secretion was decreased by Wnt treatment. And we also found that this decreased insulin secretion was recovered by beta-catenin antagonist. And as beta-catenin is the downstream signaling of Wnt beta-catenin pathway, we consider that Wnt beta-catenin pathway have affected on the insulin secretion, and it made a impaired insulin secretion in beta cell in the pancreatic cancer patients. And we're still working on the other potential signaling mediators and potential molecules other than Wnt beta-catenin pathways based on the gene set enrichment analysis using the public microarray data sets. And we're still working on searching for the other potential molecules on it, and still working on the other ex vivo experiment as well.
So would you think that this is relevant outside the pancreatic cancer realm? So do you think that Wnt signaling in principle is affecting beta cell secretion? And for instance, when Elina transplants the eyelid into a non-normal space, there might be a different Wnt signaling in this sort of realm. Would you think that plays a role there? And could you potentially overcome that with gut peptide signaling onto the same cells? Or, I mean, this is very speculative, but have you thought about this?
We thought that maybe there could be a variant Wnt beta-catenin dysfunction in the pancreatic cancer patient beta cells. But originally we thought that those aberrant Wnt beta-catenin pathway would be working on in the paracrine fashion as a paraneoplastic syndrome. Because after surgical removal of pancreatic original tumor mass, there was a significant improvement in insulin secretion and glycemic control. If there was a original dysregulation in beta cells, if there was, the surgical removal would not induce an improvement. But if those aberrant signaling working as a paracrine fashion, the surgical removal of pancreatic mass would work, and those deterioration of hyperglycemia would be improved after the surgery. So we thought that improvement can be made after the removal of the tumor mass and the causes.
Okay.
Thank you.
Elina, your data suggests that it's not just an acute effect on of bariatric surgery on the islet function, but actually is a more long-term effect on islet survival and function and connectivity. So could that be something that is not gut hormone dependent, but a more fundamental process like a Wnt pathway, or something that might affect vascularization or islets sort of?
Absolutely. And I actually think that the idea that Min actually said is it would be a really nice idea to do this to the islets before we transplant them and see what would happen. Yeah, I think we could actually follow through with that. Yeah, it seems to be a chronic thing. We expected this to be a very acute effect that, okay, the animals lose a lot of weight the first 2 weeks and they are on liquid diet. And we expect like a peak, and we did see a peak on the first week on the islet function. And then they start regaining weight, given that it's not the same as the shams. They never reach exactly the same point. But the leans do, and the leans never lost weight, and they have the same effect. So yeah, it seems to be like 3 months after surgery when they're not lean, they're at 42 grams, but their islets are still extremely active and the shams are dropping by the week. So yeah, I mean, as far as I can see it, it's definitely a chronic effect. We can never completely remove the weight loss, because even if you do pair feed them, they still lose a little bit more. The truth is that you need the model of the duodenal jejunal bypass to completely eliminate weight loss and just examine what the gut is doing. Because even the sleeve, the stomach is expanding back after a couple of months. As I'm guessing you've seen with your models. So yeah, I think that it's chronic. Why is it chronic? We are planning to find out if by implanting pumps with Exendin 9, and then also try to antagonize PYY. But at a molecular level, that would be the real question. And maybe that would be the way to do it on the islets when they're isolated, then do ex vivo and then try to transplant them again. So yeah, I would really like to see this at a molecular level, because we do lack a very clear mechanism molecularly at this point.
I have a question for discussion also. I think one thing that you also looked into sleeve gastrectomy, and one thing that actually challenges this hindgut hypothesis and the role of the distal gut is the effect of a sleeve gastrectomy, because we have also performed studies where we have compared sleeve patients to non-operated controls and to gastric bypass patients, and what we find is that we have this procedure sleeve that has fairly similar metabolic benefits to gastric bypass surgery, but the most important hormonal finding in sleeve patient is a very low ghrelin secretion, and their distal gut hormone secretion is much more similar to non-operated patients than it is to gastric bypass patients. So I think that is also evidence that, as we also discussed, that definitely there are other mechanisms in play, and perhaps we need to focus a bit more on ghrelin or other possible factors, bile acids or other factors, if we want to really understand this effect of bariatric surgery.
And ghrelin is linked to bile acids. Ghrelin is activating bile acids. Sorry. So I completely agree. Ghrelin is just like a hormone. It's linked to bile acids more than any other hormone. So yeah, we still don't know where ghrelin goes after sleep. Some studies say it goes up, some studies say it goes down. So it really seems to be in the eye of the beholder of the hospital, or where it actually is going, especially after sleep. But the fact that it's the only hormone that activates bile acids, and there's a very direct hypothesis that I agree we should be playing with. Sorry.
I think I wouldn't.
I'm going to draw this to a close, because
Okay.
I think we've had a great conversation, and I think we could carry on chatting for a long time. And I think what it has done is to highlight actually how little we understand about how bariatric surgery works. And there's been a lot of focus on the gut hormones like GLP-1 and PYY, but I think, as we've all been discussing now and during the session, it probably isn't just these, and there are many other factors that we still all need to think about in terms of how you improve insulin secretion and eyelid survival. So I'd like to thank you all very much for joining us for this discussion after the EASD presentations. Thank you very much.
Thank you.
Thank
Okay,
you.
thank you.